Very good evening, everyone. Welcome to iFocus Online, lecture 244, number 31 in our series from Squint and Pediatric Ophthalmology. Today, we have with us our very own Professor Amitava sir from AMU Aligarh, talking to us on all you wanted to know about nystagmus, a dynamic topic, as he said himself, for our dynamic speaker. I invite Pradeep Sharma sir to please welcome him and introduce him to our audience.
Thank you, Shefali. It's once again a great pleasure to welcome Dr. Amitava, who has been co-chairing in several of our sessions to talk about a subject which is interesting and complex. Professor Amitava Abadan has done his MBBS MS from AFMC Pune, and then he's had a 5-year stint in the army, and then 4 years in 200 years old 4th Battalion Brigade of Guards. So he's a very disciplined soldier, even in ophthalmology. He's a faculty at Gandhi Eye Hospital, Aligarh, for the 3 years. And then currently he's a senior faculty at JN Medical College, Aligarh Muslim University. He has been a past secretary of Strabismological Society of India. Currently, he's the president of Strabismological and Paediatric Ophthalmology Society of India, SSI. He has done novel research in popularized primary true muscle transplantation as alternative approach in uniocular large angle isotropias. He has also done an RCT cut and paste recession surgeries using cyanoacrylate sutureless strabismus surgeries. He recently did an RCT on a refocused attention application as an alternative to resections. He's an avid reader, fond of biostatistics, long drives, trekking, and amateur birder. So we look forward to this talk on all you wanted to know about nystagmus from Dr. Amitava Abadan. So, Dr. Amitava.
Thank you so much, sir. And I'm very humbled to be in the presence of somebody like Professor Pradeep Sharma. And also, I'm grateful to the iFocus team to have given me this chance to speak here. And for Dr. Honawar and his team, and Dr. Shefali, who hosts it so well. So let me just start off with nystagmus and see what we can pick up from here. Particularly, I'm addressing the postgraduate. Now, at the end of this, we should be able to better understand what is nystagmus, get a brief overview of its classification, and see some examples of the common ones, and what we can do as ophthalmologists when we have this situation. Now, on the right, you will notice is a picture of the most important part, which is the brainstem and the cerebellum at the back, because this is the vital space in which most of these explanations lie. And if you can see that, you will notice that there is the midbrain is on top. The big paunchy thing is the pons, and below the vestibulum, which then translates into the spinal cord. And I've put in red the areas like the cerebellopontine angle where the Brun nystagmus take place, the pontine area where the bobbing nystagmus kind of thing take place, which is vertical, the eccentric gaze nystagmus where the horizontal gaze integrator, which is the combination of the nucleus prepositus hypoglossae and the vestibular nucleus, which stabilizes gazes in the horizontal directions. Similarly, if you go more vertically around the midbrain, the rostral interstitial nucleus of the medial longitudinal fasciculus, which is the vertical gaze center, and the interstitial nucleus of Kajal, which is the neural integrator for vertical gaze. They're there in the midbrain. And structures here can also get affected, as in the posterior commissure, the convergence retraction nystagmus. Some of these, like the CRN and the internuclear ophthalmopedia, where the MLF, the medial longitudinal fasciculus lies, are not, in my opinion, truly nystagmus, but they are discussed very often with this term nystagmus. So we'll have a look at them. So to begin, therefore, if you look below, is the classic definition of what is nystagmus. It's involuntary, rhythmic, oscillatory eye movements. And the important thing to remember is the first phase is always the slow one. It's a drift. It can be followed by a slow phase or often a fast phase, which is a jerk. And that is the second part of the movement, which defines a nystagmus as a pendular, which is just both the things are slow, or a jerk. Now, if you see the overview of the classification, you see I've split it into 5. The top one is the physiological nystagmus, which is actually a sign of health. So that's the vestibulo-ocular reflex we'll see, because it will also explain how the vestibular nystagmus takes place. The optokinetic nystagmus, and I like the term OKN. It's quite the OK nystagmus. It's a sign of health again. And we look at the Gaze nystagmus, which is again not anything pathological, but because the neural integrator is getting stressed out in extremes of gaze. And then I have a subset called the early onset or infantile onset nystagmus, which has the infantile nystagmus syndrome, the fusional maldevelopmental nystagmus syndrome, and the spasmus Newton syndrome. And I have actually grown up for most of my earlier part of my ophthalmology life as calling it as latent and manifest latent, the INS. But as we'll see, terminologies have changed over the last 2 decades, and we should adopt the more rational one now. The ones listed under 3 are the ones that we should be worried about, where neurological consult or a CT or MRI may be needed. And what is also important is to remember that some of the early onset ones may have a superimposed later onset strabismus, nystagmus. And that is why a change in character of nystagmus is also a red flag that one should remember to get concerned about nystagmus. So here we'll be looking at the vestibular nystagmus, which comes in 3 flavors, 2 of which involves an imbalance of the vestibular input. One is from the periphery, so it's the peripheral vestibular imbalance nystagmus. Then the central vestibular imbalance nystagmus. This is the one which has the downbeat and the upbeat portion, or where the vestibular input is unstable, and that leads to a periodic alternating nystagmus. So these are all old terms. This is now being called the central vestibular instability nystagmus. But you will find me switching back into some of the old terms also. The second one here, under the bigger heading of 3, is the gaze holding deficiency nystagmus. Here's where the neural integrator is at fault. And here we'll have the eccentric gaze nystagmus, which also includes the rebound nystagmus and something called the runaway nystagmus. Third is the vision loss nystagmus, which has an aspect whether it's pre, post, or a chiasmal lesion. And at the chiasmal lesion is the one we have seesaw nystagmus. Then is the pendular nystagmus associated with diseases of the central myelin. And here we know that the internuclear ophthalmoplegia is heavily myelinated, one of the most myelinated tracts in the CNS. And we'll see the pendular nystagmus there. But some of them I may not be able to show you videos, but I'll show you how it happens. And the other 2 of them are myoclonus, which has an ocular palatal tremor, and the one which is called as the myoarrhythmias, which has the gastrointestinal disease called the Whipple's disease. And this one is interesting because it has the nystagmus, which is convergence, divergence nystagmus, convergence, divergence. So that's a little different. Then the ocular bobbing. And this is the one which reminds me of those water balloons that you would get in the hill station in India, which have a rubber string and you throw it down. So it has a rapid movement down and it comes back a little more slowly, quick action down slowly. And that's the kind of movement that happens. And pathology is usually in the pons. You can have an inverse bobbing also. So, and these are very rare and uncommon things. I haven't seen any case. And then the fourth one is what I call it Nystagmus Mimics. And these are not nystagmus at all, but they are ocular movement oscillation disorders, which have, the important thing to remember is the first phase is fast. So it is the saccade which takes the eye off the target. And these come in different names with square waves, pulses, and I'll have a slide which we can see how we can understand them. What are saccades, what are flutters, and what's an opsoclonus. And like I told you, we've had the convergence retraction nystagmus, which is, usually they would say it's the Parinot syndrome, the midbrain syndrome. And if you recall, that's the place where we had the upgaze center. So when pathology strikes there, the patients are not able to look up, and they have also light near dissociation. And in the effort to look up, they actually have so much of the neural output that it kind of spreads into all the recti, which causes a retraction of the eyeball. And the medial rectus seems to be the strongest muscle at that point of time, and it causes convergence. So what we get are jerks of retracting eyeballs, which are also converging. So it's called convergence retraction nystagmus. so why I think you should not call it nystagmus is because it's really not involuntary. You can actually ask somebody to look up, and it may be demonstrated, or even if you vertically roll the optokinetic nystagmus drum downward, so that you force a rapid movement upward, and which is what the person can't do with this syndrome, you'll be able to elicit the convergence retraction nystagmus. And so also the abducting nystagmus of the internuclear ophthalmoplegia. We'll have a look at that. So first, a little bit about the backgrounds to the types of eye movement. I've split them into those which maintain gaze and those which change gaze on the right. The first thing of course is to fixate. If we are fixating at some object like this cat is doing in this picture, we can see we actually get small tiny movements, and these tiny movements are appropriately called a micro tremor, micro slow drift, or a micro saccade. And these actually aid vision. And I remember that even in school, in the Reader's Digest, I remember reading that when you wanted to look at stars at night, you see there's such feeble light, and it would blanch the retina that you had to move your eye a little bit so that another cone would get stimulated to be able to make some sense out of that light. So there are these micro movements taking place. They're not easy to see, but they're very much there. In case you're not fixating at an object, but you hear a sound somewhere on the side, or for some reason something strikes you in the periphery, or you just want to look at some particular place, the brain senses it by what is called as the saccade position error. And that is what drives the saccade to look in that direction. And that's when you start fixating. But to maintain that fixation, we look at these two things, the vestibulo-ocular reflex and the optokinetic reflex. And I've got some videos to show for that. It's also important to remember that the vestibulo-ocular reflex can be cancelled. And I'll show you why that is important. We'll have a look at the saccade, the smooth pursuit, and the midbrain, the brainstem pathways which carry these instructions, so that we understand the INO. Vergence, like I've said, is also a change in gaze, but it's a distance and proximity change of gaze. But do remember that a target may move from your left to the right and also come closer. So these all work together. Now, as you can see that on your left is my student who's been asked to move her head as she's reading something. So we can see as the head turns to the left and right, the eyeballs stay in position. That is the vestibulo-ocular reflex. And on your right, you'll see that, I'll show that again. On your right, she is looking at these rotating lines. So this is on an app, of course, but you will be able to see the movement of the eyeballs as we look here. They will follow those lines. And as those lines disappear to her left, then she makes a saccade to the right to pick up another line. This is the typical railroad nystagmus. And when we look at the central picture, it's the same student who's been asked to move ahead more or less like she was doing to demonstrate the vestibulo-ocular reflex. But we will notice that she's now reading a book which is moving along with her. And then we'll notice how she can cancel her vestibulo-ocular reflex. So the eyes are not going left and right in the counteraction to the head movement. It's also important to look at the graphs down below that the vestibulo-ocular reflex is a very quick reflex. Within under 10 milliseconds of the head rotation, the eyes counter rotations kick off. And as you see on the right, the optokinetic reflex is much slower. There is a latent period of almost 50 to 100 milliseconds. So you can see it's comparatively slower to respond. And the eye rotates in the same direction as the motions of the surrounding, or like in this case, these zebra stripes. This one is to show the end gaze nystagmus, which is quite physiological. And what happens is when somebody looking in extreme gaze and does so for some time, the neural integrator, which is supposed to be maintaining that gaze, gets stressed out, and it tends to drift back a little bit. And because he's been asked to look to the right, he kicks in again. So you'll see jerks to the right if you ask him to look to the right, or jerks to the left if you ask him to look to the left. This is quite normal. But if the neural integrator is diseased for some reason, if it's affected by pathology, then even slightly making the gaze eccentric will kick in with a similar jerk nystagmus. looking away towards the gaze. So the old terminology was the gaze-evoked nystagmus. That is also now called the eccentric gaze nystagmus, and that would be pathological. So remember, this one is to do with the neural integrator, and I've already said where is the neural integrator there in the brainstem for the horizontal gaze particularly. And remember, this test is also used by the police abroad to find out if somebody is intoxicated with too much alcohol, because the alcohol also, and for that matter, other toxic drugs, they suppress this neural integrator. So the mere act of looking a certain degrees to the right and a certain degrees to the left kicks in with this kind of nystagmus. This we are all familiar with the Saccard's example on the left. So the girl has been asked to look to the right and to the left quickly at two objects, and the one to your right you'll see is the following or pursuit. Now, remember the Saccards, they kick in from the frontal lobe. So they are fast movement from the contralateral frontal lobe, and they come and finally impinge on the contralateral parapontine reticular formation. And as we see in the graph below, this is the ballistic action, and it's very quick. And you can see that as the eye position shifts, the eye velocity zips up and comes down. It's all over very, very quickly. Okay, and you can see how much what is the rate for about 400 degrees per second compared to the pursuit, just 20 degrees per second. Okay, and you can see it, but it goes up, but it stays for a longer time. So it is more persistent, the pursuit. And also P for pursuit, P for parietal, and is ipsilateral. So if somebody can't, on command, look to the left, that person may still be able to follow to the left if with pursuit. This is an important slide, which on the left shows the vestibulo-ocular reflex pathway, and the blue rings at the bottom are the semicircular canals. The one on our left is the right semicircular canal, and the one on the left is the on our right is the left semicircular canal. These orange ones on both sides are the anterior ones on one side, the posterior ones, and similarly the blue ones. So just to show you how they are oriented and how not just rotation to the left and right, but little turn to the right and downwards and upwards, even they stimulate the other semicircular canals. But to understand this is just good enough to focus on the horizontal semicircular canal. Now, what is important is to know that the two semicircular canals in a static position are giving some resting tone. And when we rotate our head to the left or to the right, and in this example, we are rotating the head in this direction to the right, the canal on the side of the rotation, it increases its neural output, whereas the contralateral canal, it decreases its neural output. The system is not so much the quantum of change, it is that the asymmetry tells the system that the head has turned to one side. So let's follow the right semicircular canal, which is on our left. The moment it sends more stimulations through the vestibular nerve, it goes to VN, which is the vestibular nucleus at the level of the medulla. From there, it crosses over the midline to impinge on the sixth nerve nucleus, where it synapses, and the sixth nerve then sends it to the lateral rectus of the same side, and through the medial longitudinal fasciculus, the green one, sends it to the contralateral third nerve, medial rectus subnucleus. Now remember, the lateral rectus of this eye and the medial rectus of this eye are yoked together, and you can see they've contracted, they've become tight. And these arrows, they show us that the eye is moved in this direction, to the left. And don't forget that the contralateral semicircular canal is sending inhibitory impulses in a more or less a mirrored pathway, which is inhibiting the antagonist yoke muscles. And this is how the eyes will drift away from the direction the head is turned in. Now imagine that we are not turning the head, but one peripheral vestibular system is diseased. So let us say the one on the left is diseased, this side is diseased. Its output will decrease. The output of the other one remains constant. As once again, the brain senses this asymmetry as if the head is turned, and exactly the same situation arises. The eyes will drift off to the other side. So and then because if you're asking the patient to look straight, he will quickly jerk back the eyes in the straight direction. But again, the asymmetry of a disease, of an imbalanced vestibular input will again cause a drift. And this is what happens. And the way to remember, the way I remember is that the slow movement is always towards the sicker side, and the fast movement is always towards the healthier side, the more functional semicircular canal. Now, the picture on the right, if you look below, is where the paramedian pontine reticular formation, the PPRF, is. It is right next to the sixth nerve nucleus, which is where it should be, because the abducent is purely for horizontal work. And this is the gaze center for horizontal movement. And it has these burst neurons, the excitatory burst neurons, the green one, and the inhibitory burst neuron. And the parapontine reticular formation of one side stimulates the sixth nerve nucleus. And then the pathway is exactly what we saw with the vestibular ocular reflex pathway. Goes to the yoke, left lateral rectus or right lateral rectus, and the left medial rectus in this case, and causes both the eyes to deviate on this side. But remember, as far as the PPRF is concerned, the saccades, again, fast movements come from the contralateral prefrontal gyrus, and the pursuit, the follow to the right, will come from the ipsilateral parietal lobe. Finally, they have to go through the PPRF. That is the final common pathway. And I've shown here the INO, that internuclear ophthalmoplegia, because if this particular green connecting and heavily myelinated tract gets affected, and we are ordering the patient to look to the left, so obviously the medial rectus of this side will not contract. The lateral rectus will, of course, contract. So we will get an adduction deficit on the side of the pathology, and the left eye will appear to just abduct and in jerks. The explanation is that the system is still trying to recruit the medial rectus. So it's still making an effort to send impulses, but they also go to the lateral rectus, and that we see an abducting nystagmus. I believe it's better considered a pseudo nystagmus or a mimic. It's important to also look at the waveform. Now, not very many places have the chance of looking at the waveform, but they can be diagnostic. So if you look below, is to explain that the vertically is the amplitude, and along to the left and to the right is the time factor. And it's also telling you the direction of fixation. And if we see this black line, we will see that it's drifting away from fixation and then rapidly goes back to fixate, and then drifts away and rapidly goes on to fixate. And because we see this line becomes more and more steep here, so this is an accelerating slow phase, a fast phase, an accelerating slow phase, and a fast phase. And this place where I've labeled as foveation, for a brief moment, there's hardly any change in, it's not covering any distance, so there is hardly any change in velocity. And that is the time when the eye is actually trying to pick up visual signals, and that's called the foveation time. And the entire one slow phase and one fast phase forms a cycle. Now, if you look at the four classic descriptors of waveforms, we'll see the pendular nystagmus is just a sinusoidal one, and it is found in the infantile nystagmus syndrome and also in the later onset pendular nystagmus that can happen. The lower one you can see is now the accelerating slow phase, and this is typical of the infantile nystagmus syndrome. The third one you can see is going up faster. There's more steepness to begin with and become more flatter here, so it slows down. This is a decelerating slow phase, and this is part of the gaze-evoked nystagmus where the neural integrator is getting affected, and actually the eyes are passively drifting back in position, and they are slowing down because the all the other tissues in the orbit are kind of making it stop. So this kind of slows down. There's always a decelerating slow phase. The last one, the vestibular nystagmus, has a linear velocity. The asymmetry in the vestibular input, the imbalance, is driving the slow phase. So it has a constant velocity. There's no acceleration. It's also easy to remember. It looks like a lot of V's in the sawtooth appearance. So that's part of the vestibular nystagmus. Apart from looking at the waveforms, it's also important to see the behavior of the nystagmus or the eyes in forward gaze when the person fixates. And why is that important? Because as compared to the peripheral vestibular nystagmus, it gets dampened with fixation in primary gaze. Whereas the central vestibular nystagmus, both are imbalances. Both can look remarkably similar. Both can have a lot of triggers which may be similar. But if you put these plus 20 glasses like I've got made, this picture is mine own, it ruptures fixation. So the peripheral nystagmus, which may have been dampened with fixation, will become more obvious. So either it becomes completely obvious, that means it was completely hidden, or it may get exacerbated with wearing these M glasses or magnifying glasses. I'm also of the view that these glasses will help a small movement also increase in size and visibility. So it not only does static magnification, it also magnifies movement. It's also important to look at in different gazes, up and down, to elicit, and we'll see a couple of examples. We must do the shaking head also and position of the head. There are various other triggers, including hyperventilation, sometimes the Valsalva's maneuver, if you need to go into the details of that. I also recommend now that we all make a nystagmogram, much like we did for strabismus, or we do for strabismus, the strabismogram. And there are a lot of ways to do that. I prefer this one, where it is not the length of line which shows the amplitude, but the number of lines which show the amplitude, as a small amplitude, a moderate or a large amplitude. And the number of fins on the tails tell you if the frequency is slow, moderate, or a high frequency nystagmus. And here's an example of a nystagmogram. The big zeros show you that that's the area of the null. You can see nystagmus might change in the down gaze. The nystagmus is a vertical pendular nystagmus with a greater amplitude in levo depression, and a change in direction between dextro elevation and in most of the other areas. So a nystagmogram is an important thing to record nystagmus. Now we come to some of these examples, and this one is example of an infantile nystagmus syndrome. Alone, by alone I mean there is no strabismus, there is no head posture. You can see that it's not so intense in primary gaze. You can see the intensity increasing, is becoming left-sided jerk in left gaze, and you can see as they look to the right, you may notice a right-sided jerk in right gaze. So this one comes in a lot of flavors. The important thing to remember is that they often have null point, eccentric null, in which case they'll have an abnormal head posture. Many of them dampen with convergence also, which can also cause an abnormal head posture, because they converge to dampen the nystagmus, and then they turn their eyes so that one of the dampened eyes is looking at the target of interest. And on the eye movement recording, that's the EMR, the typical waveform is an accelerating slow phase. This one also shows that quite a few of them have some visual afferent defects, whether this is aniridia or this is achromatopsia, and one should always search for visual afferent problems. It used to be called as sensory deficit nystagmus in the old parlance. And this one shows you that both strabismus is also common with infantile nystagmus syndrome, and you might notice the head seems to have a little bobbing also. And there is a little tremor of the head here, if you notice. That is also common. Head shaking is also common with INS. This one is an example of the fusion maldevelopmental nystagmus syndrome and the classic description of what used to be the latent nystagmus. So as you cover it up, you'll see that the eyes seem to drift toward the cover and beats away. Drift toward the cover, it always beats away. Even the eye which is covered is beating away. We're not able to seeing it. And this beating away from the cover or towards the seeing eye can change. If you cover the other eye, it will beat now towards the left. So this is also one of those which can reverse. And the caveat here is when you're testing visual acuity in such scenarios, it is best not to completely, monocularly block one eye. You can use a +10 or a +20 lens so that some light is going in and it doesn't stimulate a latent nystagmus. It's no more called a latent nystagmus. I was reading about it, and they said actually there is really nothing latent. It's just so fine that we may not be able to pick it up. It becomes more obvious when we disrupt fusion. So I think the term now is the fusion maldevelopment nystagmus syndrome. Even the term manifest latent nystagmus used to be considered an oxymoron. as if both things can happen. So just that gets exaggerated with a cover. And this one is from Dr. Shubhangi being kind enough to share it. And you'll notice that, there's so much exotropia. There is a face turn. The child is looking at the target with the adducting eye. There was DVD. There was an A phenomenon. And she did surgeries for all of these things. I mean, she did surgeries for the abnormal head position. And we'll see a slide on that. How do we plan that surgery? She did for the exotropia, for the DVD, and even for the A, she did superior oblique tenotomies. And we can see the picture on the next side, and the patient looking so much better, and he was performing so much better. We'll see that, therefore, there is a lot of gain in treating nystagmus. This one has been shared by my colleague, Dr. Sunil from Dharan, and to show the spasmus Newton syndrome. So you can see how obvious the head bobbing is. In fact, the eye movement is a pendular shimmering nystagmus, not often picked up by the parents. The head bobbing often comes later, and it is for the head bobbing that they get the child. And the third part of the triad is the little torticollis. And it is considered that the head bobbing and the torticollis somehow helps to improve vision. It's not that the head bobbing neutralizes the shimmering nystagmus. Otherwise, the bobbing also would be a inverse shimmering. But it is seen that the eye movement recordings during head bobbing are much better. That means they allow a little more foveation than during without the head bobbing. So in that sense, it is helpful. Now, the interesting thing is that the classical spasmus Newton syndrome is benign. It starts off around 1 year of age, usually peters off in another 2 to 3 years, sometimes by up to 8 years, and nothing needs to be done. But spasmus Newton, like nystagmus, is also associated with chiasmal or suprachiasmal lesion and sometimes with retinal dystrophies. Now, it's okay for clinically to check out the retina for dystrophies. Either you look for something visually or you do an ERG or something. But it is advisable because to find out whether it is benign or the dangerous kind, you'll have to wait till it recovers, the patient recovers, and that could be dicey. So the current recommendation is that if you do get these children, it is better to do an MRI. In this case, the MRI was done and nothing was found. And as the child grew up, the nystagmus disappeared. Now, this is Brun nystagmus, and I remember that about maybe a week or two ago, this was brought up again by one of these speakers on this program itself. But I have tried to show you that with a cerebellopontine angle tumor, now if you remember the anatomy, you'll see that that's where the neural integrators is the horizontal neural integrator. That is the nucleus prepositus hypoglossi. That's also where the vestibular nucleus is. So this is a mixture of an integrator malfunctioning, that means inability to hold gaze to the left in the direction of the tumor, and a vestibular nystagmus beating to the other side, which is a fine nystagmus, because of the vestibular imbalance that we've just talked about. So we'll have a look at it, look carefully. A more coarse nystagmus to the side of the tumor, that's to the left. Okay, that's the gaze holding deficit nystagmus. And as the person looks to the right, that's the more fine beating and a right beating nystagmus because of the vestibular imbalance that is there. Now, in most of these vestibular nystagmuses, whether peripheral, central, whether because of imbalance or instability, we do get vertigo, nausea, dizziness, and oscillopsia. And most of these pathological nystagmuses, they warrant some neurological consult or a CT or an MRI. And as you can see, the MRI shows the tumor there on our right. This was shared by Dr. Shubhangi, and this shows a downbeat nystagmus, which is basically a central vestibular imbalance nystagmus, but here and classically described in Chiari malformation as this patient had. And the image on the right doesn't belong to this patient. I've downloaded it from the net to just show you where the problem lies in a Chiari malformation. And you may see that it is sometimes more in dextro depression or in levo depression because the gaze evoked element also kicks in. So the gaze evoked nystagmus may improve the visibility of just a downbeat nystagmus. This one again from Dharan shows that there was some afferent glioma of one eye, optic nerve, and you will see that that's typically described as visual non-nystagmus, pre-chiasmal, with vertical oscillations in the blind eye. And it's a pendular one. This one will show us that if we look from below, that there are just square waves. So it looks like a physical square. It basically takes the eye off the target, pauses for a brief moment, and then returns. So that's called a square wave jerk, just a single one. We are looking at the bottom picture. Then you can see that there is a series of these square waves. So they can come in series. There could be just a single pulse, so it takes it off, and then it drifts back. Or there could be a double saccade that drifts off, drifts back. The second one from the bottom, you will see that it's going to the left, going to the right, and it's increasing. And it's called a macro saccade if it is more than 5 degrees off target. Those square wave jerks are less than 2 degrees off target. And they pause, this flat area on top is where it pauses for about 200 milliseconds. That's the intersaccadic interval. But if the middle picture, if you see, is a back-to-back saccade, there are no pauses. All are quick movements, rapid movements. That's called a flutter. And if it takes place in all chaotic directions, it has this terrific name, saccadomania, also called the opsoclonus. If it takes it off the target, you don't read the target, you go beyond it. That's a dysmetria. So this kind of a picture would be a flutter dysmetria. And this one would be a saccadic dysmetria, the one on top. And it's important to remember that all of these, they are ocular movement disorders, but they don't classify as nystagmus because the movement which takes them off the target is a fast movement, and they come with cerebral or cerebellar cortical diseases, and this warrants a workup, a neurological workup. Now, what can we do? The first thing is we should red flag the worrying nystagmus, and the mnemonic I picked up is AMPT, which means an altering character, by which I mean somebody could have an infantile nystagmus syndrome, correctly diagnosed too, you're not so worried, but he may later on get a vestibular nystagmus that you might worry about. Mixed directions, P is for pendular nystagmus, acquired pendular, gaze evoked, whether neural integrator is at fault, or disjugate nystagmus. These should worry us, and we should be worried about the brainstem and the cerebellum being affected. What can we do? We can do a lot. The first is we can give the refractive correction where required. And here the contact lens are considered way superior than spectacles, because not only does it improve the optics better, it also moves with the eyes. And when it does that, even if there's an abnormal head posture and the child is looking with a preferred gaze, the contact lenses are still doing the optimum job, but the glasses will not. They can be tinted. And it's now known that the mere contact of the contact lenses on the eyes also dampens nystagmus. So we can understand that it's supposed to be a superior thing. There are a lot of drugs, aminopyridine, baclofen, particularly for the ones which have oscillopsia, clonazepam, gabapentin, and memantine for the infantile nystagmus syndrome. But I would be reluctant to start these on without a consultation with a neurologist or a neuro-ophthalmologist. There are some reports now of Botox being given, and the idea is to silence the muscles. But we can understand that we can get a complete paralysis, then a recovery. But reports do suggest that there is some benefit. But more often than not, we are now resorting to surgeries to provide the improvements on a lot of things. And what has come in the last many years now is the enthesial disruption. That means where the tendon is attached to the sclera, that's the part of the enthesis, and you do a tenotomy and a reattachment to the same place itself. And this surgery at the extraocular muscle insertion, by modifying some proprioceptive feedback to the central ocular motor controls, it favorably affects the nystagmus oscillation. And as I show you in the end, that this last sentence here, that it's not just improving the null, it is improving the quality of life, improving vision by improving foveation time, better recognition of the objects, reducing or absolving the compensatory head posture, the associated strabismus, and it does broaden and deepen the null. So if you look at this algorithm, that is a patient with nystagmus. If it has isolating nystagmus, they would do the 4 horizontal rectus recessions in the past. I've also done a couple of 4 horizontal muscle recessions in the past. But now they recommend that you just do all the 4 muscles, tenotomy and reattachment. If there is a head turn, then we'll see what is to be done, and we look at the picture on the side. If there is associated strabismus, then here's the interesting part. You do the Nystagmus surgery for the measurement of the deviation of the head posture in the fixating eye, and the residual surgery in the fellow eye, you do strabismus surgery on that. So you can look after the head turn and the strabismus. If there is both, so we combine both. Okay, otherwise we just do the strabismus surgery. Now, if you look at the picture on the right, this is somebody who has come with a rotational head posture, a torsional head posture. And the paper from which I've taken this, there's Paris paper in the Indian Journal. This is the surgery they did. They did this in the right eye, they did the superior oblique anterior tenotomy. On the left eye, a superior oblique Harada-Ito procedure, and the inferior oblique recessions. So they were basically turning the eyes to the same size as the head is turned. So in the right eye, they were weakening the intortus, that is the superior oblique. On the left eye, they were weakening the extortus, that is the inferior oblique. And they were also tightening the intortus, that is the superior oblique, by doing a Harada-Ito. But now Hertel, that's the gentleman who was there, the workshop with the CMA's workshop, they suggest just a shift of the upper vertical recti and the lower vertical recti in both the eyes. And the way to remember is that the upper vertical recti are shifted 1 full tendon width toward the upper ear, and the lower vertical recti toward the lower ear. And that also brings the torsional change. Now, the Kestenbaum-Anderson's surgery, and again, there would be many here who would have done this, so as have I, would involve a resect procedure. And these numbers given here were the numbers for a classic amount. But later on, it was found that if it exceeded by 20 degrees of face turn, you should augment these numbers by 20%. If it was beyond 40 degrees, by 40%, and anywhere in between by 30%, and some other variations on this theme. But that was the way it is. And for all, for nystagmus without a face turn, all the 4 recti were recessed. But like I said, now all the 4 recti would be just tenotomized and reattached. So here's we're coming to the end now. I won't take long, but I've divided the Hertel's breakup of a series of surgeries for the infantile nystagmus syndrome to the condition, if they have a compensatory head posture, if they have strabismus, and if they have nystagmus, of course, but if they have both the head posture and strabismus. So if you look at the first one, which is 1 in 5 condition, and they have a horizontal head posture, and because of an eccentric null, you need to just recess, if it is small degrees, that's 25 or less, you need to weaken the pulling muscles. That's the lateral rectus on the one side and the medial rectus on the other, by these numbers 10 and 7. And the recti, the contralateral recti, are tenotomized and reattached. So at the end, all the 4 muscles are being, disinserted and reattached. 2 at exactly the same point, and the other 2 at a different point to compensate for the head posture. And therefore, they're getting benefits in this. If it's a large angle, then you may have to do the recessions along with resections, in which case the green part, the nystagmus, you don't need to do, because all the 4 recti have been tenotomized and reattached, even if not in the exact location. We look at 2 and 4 together because one is chin down head posture, one is chin up head posture. Now, what Hertel recommends here is if it is chin down and you have to move the eyes in the down position, then you knock off all the muscles which are causing the, in this case, chin down. So the eyes are up, inferior oblique myectomy and superior oblique recession. This will bring the eye down because inferior oblique is an elevator. And in which case, if there is strabismus, you do a bilateral symmetrical surgery, either bilateral recession or resection. But you don't operate on more than 2 recti because you've already got a vertical recti there, and that might compromise the anterior segment circulation. So the very much opposite is in there in the chin up. So also, if there is no compensatory head posture, just a strabismus, that's the serial number 3. Then you do just bilateral surgeries. If you know single muscle in each eye, that's good enough. Then you must support it with tenotomy and reattachment to the same location of the recti you have not done any strabismus surgery on. But if you're doing surgeries on all the 4 recti, then you at the end tenotomized and reattached all the 4 recti. So now if you look at point number 6 here, that there is only an infantile nystagmus syndrome, no head posture, no strabismus. So the yellow one is free, the blue one is free, and you just go to the green column. All the 4 recti, like I said, tenotomized and reattached. The 8th one is another interesting one. This again, like I said, in the infantile nystagmus syndrome, if there's convergence dampening, then all you need to do is cause artificial divergence by recessing both the medial recti about 3 millimeters. And so the patient needs to see, he needs to converge, and that's what dampens the nystagmus. The torsion one we've already looked at. At the end, then, we just need to see that if the nystagmus onset is in infancy and the history and examination suggests that there is no oscillopsia, normal growth and development, there's a family history of nystagmus and strabismus. They have a head posture, that means there is some null. They have a latent component. It dampens with vergence, or there is some other eye disease that you found out. Even if you don't have the eye movement recording, you really don't need to do a neurological workup, and a visual system workup would be sufficient. But of course, if you have an eye movement recording, and that gives you a suggestion whether it is the infantile nystagmus syndrome type, the childhood onset type, or the later onset type, the more worrying kind, in which case we need to do a neurological workup, including now genetic testing. Thank you. I hope I haven't caused oscillopsia to anybody.
Thank you so much, Amitava sir. Indeed, a very complex topic and complex charts, but I think you made it very clear for our postgraduates. Sir, Pradeep Samar sir, concluding remarks from you, like a wrap up of sir's talk.
I think it's difficult to wrap up such a subject. It's so complex. I think if you see the eye movement systems that we have and the way diverse that they are placed all over the brain, it's a miracle that we have normal eye movements without any nystagmus. I think we should be thanking God that we do not have any nystagmus or a nystagmoid movement in spite of all this complexity, which can go wrong in any one place and there would be a problem. So I think for the postgraduates, I think Dr. Amitava has tried to make it clear that nystagmus is a condition in which there is a regular rhythmic movement as against a nystagmoid movement. So many of them would be nystagmoid movements which are not regular or rhythmic. So they would be declassified from the term of nystagmus. Conditions like the convergence retraction nystagmus or the Hyman-Bilchowski's phenomenon, which is there in a blind eye or a semi-blind eye, or so these should be nystagmoid movements, or even the saccadomanias or opsoclonus, ocular bobbing. All these will come in the terms of nystagmoid movements and not a nystagmus, which is supposed to be regular rhythmic to and fro movements of the eyes. Nystagmus may be bilateral conjugate or it may be disconjugate. So that again we have to keep in mind that if they are disconjugate, you have to be having red flags. So what I generally tell my students is that if you have a unilateral or a disconjugate nystagmus, if you have a vertical nystagmus, if you have an acquired nystagmus, if you have an oscillopsia, then you need to do imaging. If you have poor vision, which is not explained by just the nystagmus, then you should always look into the fundus and do an ERG in addition to whatever examination that you do. Otherwise, nystagmus per se, if it is an infantile nystagmus or a manifest latent nystagmus, which is now known as fusional maldevelopment nystagmus, usually the visual acuity is explained by the nystagmus that is there. If you cannot explain, then always look into the fundus, do an electroretinography to explain. There must be something in the retina which is giving rise to that, which we will call in that case as a sensory nystagmus. So, I mean, these are certain terms that we should be remembering. Dr. Amitava presented elaborately the different eye movement systems and how they can go wrong, which causes the nystagmus. I think we can have the questions from people. In management, again, he has described a pattern which is followed by Dr. Hertel. You may have a little different approach. I personally, feel that the Hertel-Deloso procedure, which is usually recommended by that group on the basis of this enthusial disruption, we have seen that it doesn't work more than 3 months. So, the effect is only for about 3 months, and then the nystagmus comes back. So I usually do not do that for that particular reason alone. I personally feel that if you do not have an eccentric head position, then the nystagmus surgeries are not so rewarding. The only other situation in which they will be rewarding is the periodic alternating nystagmus, in which case you can do the 4 horizontal recti muscle surgeries. But otherwise, if you have an eccentric null position with a abnormal head posture, whether it is horizontal or it's a vertical or a torsional, it is a very rewarding surgery, very gratifying surgery. The other surgery which also can be helpful sometimes, which again would be a caveat that you can do, is the inducing convergence by doing a medial rectus recession or a posterior fixation on the medial recti to induce more convergence, because we know that any convergence innervation dampens the nystagmus. So that's another surgery which helps. Otherwise, if you have an associated strabismus, that also needs to be taken care of, not only for cosmesis, but also in cases of fusional maldevelopment nystagmus. It's seen that if you correct the squint itself, the nystagmus becomes better, the manifest component becomes latent, and so the vision improves. So these are some general comments, and we can now move on to the questions specifically from the people.
So one of the questions was red flags in nystagmus. I think sir has covered it right now. Next one is, can you please explain the concept of foveation time in pendular nystagmus associated with oculocutaneous albinism?
See, foveation time is a general concept. It's not just with ocular albinism, but as those waveforms were showing, whenever the waveform is at a flatter portion, that means it isn't covering much distance, so there is really no velocity. That is the time when the person is best seeing, because in that moment of time, during the wave of the nystagmus, the target is on the fovea. That is all there is. Now, only if you have EMR, and if you are doing some, like all the 4 recti recession, and you are getting some improvement in the foveation time, that means the duration for the length of time that the target is on the fovea, and then you may get some improvement in visual acuity. But they don't work very well. Most of the time, they say that 50% of the time, people may improve visual acuity by 1 line. 50% of the time, there may be no improvement. Nobody visual acuity falls. But somebody with albinism is likely to have already some foveal aplasias and such issues. And they may not really benefit much from the surgery, which may only, even if they change the waveform, we have an abundance of other problems in say, albinism for real benefit to accrue. Expectation would be pretty low in that situation. But I think sir can, maybe divulge more information.
So I think what one should remember is oculocutaneous albinism is not necessarily a cause of nystagmus. It's an fellow or a co-traveler. Both the genes for oculocutaneous albinism and infantile nystagmus syndrome are in the same locus. They're having a similar location. That's why most of them, they are usually there together. But you may, it's not that albinism is the cause of nystagmus. In fact, oculocutaneous albinism, as Dr. Amitava also mentioned, some of them may be having foveal hypoplasia, and that you can confirm by doing an OCT of the macula, and you can confirm that yes, there is a foveal hypoplasia, the pit is not there. And these cases will have poor vision because of a hypoplastic fovea. That is, would be a situation in which it's like a poor vision because of an organic cause. Whereas if you have a nystagmus, the situation is a little different. So when people were asking that pendular nystagmus versus foveation dynamics, one has to be very clearly understanding these facts. When we are talking of foveation dynamics, what we mean is there should be some time when the eye is allowed to, or the fixation is allowed on the fovea for at least few milliseconds. The degree of movement should be less than 2 degrees per second. So that is also, I mean, Hurtle and Deloso have defined as the NAFX, the nystagmus acuity function. So when you are recording the electronystagmography, you can actually see how much is the velocity and how much is the duration. So if that is happening, if the intensity of the nystagmus is controlled in that manner, that means it's less than 2 degrees per second and the amplitude is also less, then you can have a fairly good foveation to allow vision. It may be surprisingly seen that people may have a large frequency, but they may have good vision, as against a pendular nystagmus, which may have a very low frequency or amplitude, but have very poor vision. So it may sometimes appear as a paradox, but if you understand the foveation dynamics, you will see a pendular nystagmus has very poor foveation because the eye is already moving all the time. And it may not allow him to see clear even for a few milliseconds. Whereas if you have a jerk nystagmus in which at the end of the fast component, there is, let's say, a plateau in which the foveation is possible, then that person may have even 6/9 vision or 6/6 vision even. So infantile nystagmus syndrome cases, they have fairly good foveations at times, and then you may have good vision, whereas they do have nystagmus. On the other hand, there is a pendular nystagmus which will have usually a poorer vision because the foveation is very poor in that. It's like an analogy, I will say. There are some students who do all the mischief, but they have such good concentration, they just sit down for maybe an hour a day and they grasp everything, as against another person who is having a wandering mind all the time, studies for 12 hours a day and still gets lesser marks than a person who just studied for 1 hour with full concentration. So I think that's a sort of analogy between a good foveation with a fast jerk versus a pendular nystagmus, which is all the time moving or wandering, doesn't allow you good vision. So be careful about this. What is foveation dynamics? That is the time where the fovea is allowed to have the fixation. And they may have, if the foveation is good, then the vision may be even good in spite of a fast nystagmus.
Yeah. So Dr. Pratibha is here. She's a hot seat participant. She has asked 2 questions in the chat box: whether the nystagmus surgery is done in one sitting or requires more number of sittings.
Okay, generally it can be done in one sitting, but if you're not sure whether you need to do more or not do more, you can split it. People are known to split it. We can do this much and see if we're having a decent effect, or then we need to do more. But very often one sitting, a well-planned sitting, and like I showed you the one that Dr. Shubhangi shared, they did so much surgery. They did bilateral lateral rectus, they did the vertical rectus, they did the superior oblique tenotomies. They managed to straighten out so much. There was a huge exotropia. They did it in one sitting.
Thank you so much, sir. Another question I have, whether the Botox injection is effective, and if it is effective, what is the dose and the frequency of giving the Botox injection?
Okay, I think, you see, it will be effective because it just does the paralysis of the muscle. So it's kind of silences the firing which is taking place at the effector organ at that point of time. But we know there's the short acting, it will recover and it will kind of come back. So I mean, I don't have any experience with Botox for nystagmus, but they're not very concrete evidence like RCTs, which show that it's a great idea. But it can be used, I think, in between. I am sure Professor Sharma has more to say on this.
No, I would not recommend Botox injections for nystagmus. I think it's really not worth. One is that if you have to do it, you'll have to inject in more than one muscle. I mean, when we are injecting Botox for a paralytic strabismus, we are injecting specifically in a muscle. Whereas for a nystagmus, what people have described is injecting it retrobulbar, like Helveston described. Interestingly, I mean, he described that post-operatively, I mean, post-injection, the response that the patient was only on telephonic answering. I mean, that is what is documented. So I somehow don't get very much enamored by injection Botox for nystagmus. There is similarly another surgery which is known as the Sinski's procedure, in which they have described the full myectomy of the horizontal recti. Sinsky, as you all must be aware, the Sinsky's hook and all that, the person who is famous for doing cataract surgeries and IUL, Sinsky's IUL and all, he later on developed some interest in nystagmus cases, and he recommended doing the 4 horizontal recti using the snare, the ENT snare, and removing the entire muscle. So his objective, like what has been described for the Botox, that you will paralyze the muscle, is to take away the horizontal recti muscles. If there's a horizontal nystagmus, there won't be any nystagmus. Unfortunately, that was also followed up by Dr. Lingua. There have been recent articles, I think a few years back also, in which he tried to do a modified Sinsky's procedure, in which rather than doing the full recti snaring, he did partial. The problem was a lot of hematomas, hemorrhages, which I think would not be a thing which we would like to advocate. And then secondly, these muscles would, what left over would still attach to the sclera and create a weird strabismus and nystagmus cocktail, which would not be, again, something which is there. So both Botox and the Sinsky's procedures are working on the same principle, that you are trying to paralyze the muscles all over, which are causing a problem. I think it's like shooting the wild animals rather than taming them. In strabismus, we are interested in taming the muscles and not shooting, whether it is obliques or whether it is the nystagmus muscles. We need to tame them. First, understand what is the underlying pathology and correct it accordingly. And it is giving you very good results in most of the cases.
So I think Dr.
Thank
Pratibha
you, sir.
also attend the coming up lecture, which is actually on the role of botulinum toxin in strabismus and non-surgical approaches. I think that will give your question an answer in more detail. The last one for the day is...
You got muted.
Yeah.
Can you elaborate on psychotic intrusion?
Yeah. You see, basically, if you're looking at a target and a saccade it intrudes into that point of time and takes your eye off the target, is what is a saccadic intrusion. And it could come as just a single time thing. It may go off, take it off, pause for a few milliseconds, like about 200 milliseconds, and then you get a rapid saccade back to that fixation. So that is a saccadic intrusion. It could come as a series. It could be small, just taking it 2 degrees off the target. So that's could be the large macro saccades, take it 5 degrees or more of the target, make up in a sequence. That's what an intrusion, saccadic intrusion. It could be back-to-back saccades. That's a flutter, where it doesn't even pause for those milliseconds. It just moves up and down rapidly. It could take different direction, in which case it's saccadomania or an opsoclonus. Yeah.
I think saccades are fast time movements, which are more than 200 degrees per second. They are generally the recovery movements, either refixation or the second phase of a vestibular or a optokinetic nystagmus. These are recovery movements. Normally what we do when we are seeing or following a thing, it's a pursuit. Or when we have a head movement and then there is a vestibular ocular reflex, again, there is a slow component of the vestibular movement, which is another type of eye movement. So there is a slow component, and then there is the recovery saccade. So saccades have a purpose of just refixating the fovea. The interesting part is that you do not have any visualization during a saccade. It's known as saccadic suppression. So that's why for vision, we need slow movements like pursuit or vestibular movements or vergence, which allows you to see all through the movement. During a saccade, you can't see. But when there are unwanted saccades, they create a problem. So you need saccades as refixation movements, but you do not want them to come up in between. When you're reading a page on a book also, you are having multiple saccades. You may not realize it, but when you read from one word to the other, there is a saccade. These are small saccades which are happening. During that, you don't sense that there is any movement. You don't see any movement change. And during that phase, that's why there is a saccadic suppression. That movement is hidden from your visualization. So saccades, understand, these are fast time movements. These are recovery phase of the movements, and they are for refixation. But when they come unwanted in between, that's why they're called psychotic intrusions, unwanted intrusions. Then they create a problem.
Yeah. Okay. So with that, we have wrapped up the questions for the day. Thank you so
Sorry,
much
can I just
again.
take a minute?
Yes, sir.
Yeah. I think there are just two more points I'd like to add. One is that the vestibular ocular reflex movement is what we do when we do the Doll's maneuver in a comatose patient, provided there's no contraindication. And the idea at that point of time is to use the semicircular canal imbalances by moving the head to drive the lower motor neuron to move. It tells you the intactness of the lower motor neuron, or generally the brain stem, to quite an extent, because the third nerve nucleus is way above, the sixth nerve is way below, that things are working quite fine, is quite intact. The MLF is also doing fine. So that's one thing. And if you do really want to see the semicircular canals working in your own case, one idea is to put your hands on your eyes and move your head to the side to side. You're not here having any visual input. You can actually feel your eyeballs rolling, in contravention to the head movement.
Again, sir, thank you so much. Complicated topic, but interesting lecture and like more interesting discussion and answers to the question. I'm sure our postgraduate have like really clarified their questions and queries for the exams. Pradeep, sir, any concluding remarks for the evening?
I think thank you, Shefali, for moderating and anchoring this complex topic. And I think we now move on from, we have completed almost the different types of strabismus and ocular motility disorders. And now we'll move on to the management. So next thing, what you are going to probably introduce is going to be another direction of strabismus and ocular motility problems that we'll be talking about. So I would like to thank you, Shefali, for moderating so well, Dr. Amitava, for presenting this lecture, and all the residents and fellows who have been actively watching and asking questions, especially Dr. Prativa on the hot seat. So thank you all. We look forward to the next announcement.
Thank you so much, sir.
Thank you, Dr. Prativa, for the questions and being here with us. And next we'll meet on coming Wednesday, and we are starting off with the management part with non-surgical approaches to strabismus, when and how, and role of botulinum toxin by Dr. Renu Grover. That is on October 12th, coming Wednesday. So see you all, and thank you again, sir, and have a good night.
Thank you.
Thank you, sir.